We are live.
Good evening. I welcome everyone for today's iFocus online session. Today we have Dr. Neeraj sir as a speaker of today's session. Dr. Neeraj sir is a senior consultant at Center for Sight Eye Hospital, Ajmer. So he'll be giving a talk on the topic techniques of capsulotomy in phacoemulsification surgery. The moderator for today's session is Dr. Amit Pandey sir, a senior consultant cataract, refractive, and glaucoma services at Center for Sight Eye Hospital, Surat. And the chairperson is Dr. Colonel Vijay Kumar sir, professor, head of department at AFMC Pune. Over to you, Dr. Amit sir, for further introduction.
Good evening, everyone, and welcome to the episode 403 of iFocus Online. This is the 17th episode of the Cataract module, and we're privileged to have Dr. Neeraj Khunger sir from Center for Sight in Ajmer, and he's going to talk about a very, very important topic, capsulotomy techniques in phacoemulsification. It's a crucial step in getting your cataract surgery right. If you don't have a good capsulotomy, you can't do a good phacoemulsification. That's plain and simple. So it's a very important topic for each and everyone who's listening. So it gives me a lot of pleasure introducing our speaker, Dr. Neeraj sir. He's done his MBBS and MD from All India Institute of Medical Sciences and is currently a senior consultant at Center for Sight Eye Hospital in Ajmer. Sir is the current Vice President of Rajasthan Ophthalmic Society, and he has served as a Chairman Scientific Committee of Ajmer Ophthalmic Society and the Organizing Secretary of ROS Conference in 2013 in Ajmer. He is one of the pioneers in phacoemulsification surgery in Rajasthan, and he has participated as a faculty in live surgeries, in phaco, SICS workshops, and has multiple presentations as a faculty in various ROS conferences. He has given scientific papers, surgical videos, and instruction courses in various national and international conferences. And he has received the gold medal for distinguished services in ophthalmology by the government of Tamil Nadu in IRSI conference in 2014. It also gives me immense pleasure to introduce the chairperson of today's session, Colonel Dr. Vijay Sharma. He's done his MBBS and MS from AFMC Pune, trained in cornea and refractive surgery in RP Center AIMS. He is currently the professor and HOD Ophthalmology Department in AFMC Pune. He's been the associate editor of MJAFI, reviewer of esteemed journals, and also an executive editor of Cataract Journal. He has been an university examiner at various universities. More than 76 publications in national and international journals, has written over 14 chapters in books, and also has authored a book. He's received the Young Achiever Award from the Indian Society of Cornea and Refractive Surgeons in the year 2017. So I welcome the chairperson, and with sir's permission, I would like to ask the speaker for today to start the presentation.
Very good evening to all of you. So I'll be talking on capsulotomy techniques. Mainly, I'll be covering the anterior capsulotomy part. My talk will be basically starting from the history of capsulotomy and then going to the various present techniques available and the newer techniques that are available. And I have no financial disclosure. Now, anterior capsulotomy, how it came into vogue was that when there was a shift to ECC from ICC, So to maintain anterior and posterior chamber and retain natural anatomy and safeguard the retina. During shift to ECC, one needs to remove the nucleus and cortex and preserve posterior capsule and rim of anterior capsule to safeguard the zonular support. Initially, it was the can opener capsulotomy which was started, and it was simple and nucleus could be easily removed. This involves creation of a circular opening of 5 to 7 millimeter in diameter by a series of small tears in the anterior capsule using cystitome bent 26 gauge needle. Limitations: occurrence of anterior capsular radial tears, chances of anterior capsule tags being pulled along with cortex. Phaco is usually not possible as it could suck the whole bag, and in the bag IOL implantation with proper centration is again a challenge. Then there was a technique by the name envelope capsulotomy. This concept was by Sordilla and Bykov in 1979. It was popularized by Galland. It was safer version of can opener as it reduces the risk of capsular zip and corneal endothelium damage by facilitating intercapsular aspiration of cortical matter. Linear incision in upper 1/3 of anterior capsule, nucleus removal and cortex aspiration, and in the bag IOL placement. Radial cuts made and with vanas and capsule is torn off. The complications are asymmetrical capsular flaps, free floating capsular tags causing dysphoria, more incidence of IOL tilt and decentration as compared to CCC. Again, compatible with ECC, but not with Phaco. So then came the present day capsular axis that was popularized by Howard Gimbel and Newhan. So now the further talk will be on these topics. One is what is continuous curvilinear capsular axis, why we need continuous curvilinear capsular axis, then CCC for beginners, CCC in difficult situations, and newer technologies for capsular axis. So one by one, I'll be talking on all these. So first, what is continuous curvilinear capsular axis? It is a round central opening in anterior capsule with continuous curvilinear margin pioneered by Howard Gimbel. Ideal size is 5 to 5.5 millimeter. It is central, circular in shape. We create a small tear in anterior capsule and advance resulting flap in circular fashion by guiding the leading edge. To achieve this, one needs to understand vector forces needed to cut the elastic anterior capsule. It is balancing of shearing and tearing forces, which will be discussed and shown in the videos in later slides. CCC is stronger because of continuous smooth edge. Now coming to why we need CCC. Starting from peroperatively, because in the absence of CCC, the tags of anterior capsule can get sucked into phaco tip and can cause capsular rupture or even loss of capsular bag. The radial tear can extend to periphery and up to posterior capsule, leading to vitreous loss. Torn anterior capsule can hinder in the bag placement of IOL, especially inability to implant hydrophobic one-piece IOL. Then small rexes can cause pupillary block during hydro procedures due to ballooning of the bag's periphery or rarely rupture of posterior capsule. Post-operatively, why we need CCC? Because here the sizing is important. If it is large or eccentric and IOL overlap not achieved, there are increased chances of posterior capsular opacification. There is a poor rotational stability of the toric IOL. There can be IOL decentration with glare. And if it is small, this can lead to capsular phimosis and IOL decentration, and in extreme cases can lead to bag subluxation. Something this can happen in capsular phimosis. What are the complications of normal capsular axis? There can be occurrence of capsular tear, which may extend into posterior capsule. There can be peripheral extension. There can be eccentric shape. The sizing can be large or small. Now we will be talking on capsular axis for beginners. For the beginners, first is to choose the eye and choose the anesthesia. So it is better to start under peribulbar block rather than topical. They should select cases with good glow, clear cornea, normal depth anterior chamber. Prefer to stain initially all cases. Use good viscoelastic like sodium hyaluronate to keep AC deep. Increase magnification for better capsule visualization. Refill visco after every 90-degree cut. Do not pull vertically. Always remain parallel to the capsule. Apply tangential force and pull inwards in case of rexes running out. I'll be showing all this in the videos in the later slides. Grasp again and again near the origin for better control and make tiny tears. Prefer side port entry or make smaller main port entry and enlarge later. We are old timers, so we are doing it mainly from the main port entry. So all my videos, most of my videos, the rexes will be shown from main port entry. But nowadays, the preference is from side port entry or from a smaller main port entry. So you can see here, once we have made the tiny cut, we are using the tangential force and making tiny cuts. We are again and again holding the edge with the bent capsulotome, the cystitome, and this is how the capsular axis is completed. You can see the round, adequately sized capsular axis. And this is the final result that we are aiming at. There should be 360-degree overlap so that the lens is well centered, and the overlap also should not be too much. So in brief, the beginner should select easy eyes, staining for better visibility, frequent filling, balancing the centripetal and centrifugal forces. They should keep the flap flat and make tiny tears as shown in the video. Instrumentation, we can use either the forceps or we can use the cystitome. Forceps give us better control and precision. Pointed tips can be used for central puncture. Needle is cheap and easily available, disposable. Visco can also be injected through this if needed. Small opening, it is easier through side port and lesser visco loss occurs. Thus, we have a stable chamber. Combined use can be done in difficult cases. This is the Utrata forceps that we are talking about. Nowadays, we have micro forceps also. So then coming to staining techniques and their advantages, trypan blue and indocyanine green. Trypan blue dye is of choice due to cost, good staining, and easy availability. Staining helps in good visibility, especially in white cataracts. It decreases elasticity of anterior capsule and thus easing the capsular axis. Inject air and then dye. Count 10 and wash the AC thoroughly. Avoid staining under visco, but in case staining is not proper or you decide to stain later on, you can always do it under visco. There is no harm in that. So this is, we put the air first. We need to have a good air bubble. So we put more air and we should have a uniform air bubble here. And then we inject the dye under the air bubble, count slowly 10. And then we wash off the dye. The dye has two advantages. It increases the visibility and decreases the elasticity. So now once we have stained the capsule, it becomes easy. You can see that it is simple to do the capsular axis. Usually if we have good glow and once we are used to doing rexes, staining is not needed, only needed in white cataracts or where we don't have good glow. Now this is a case of runaway rexes. You can see that we are going and then we are seeing that the rexes is going out. So don't panic, stop. Inflate the chamber with good visco. And now you prefer the forceps. And use the forceps now, not the tangential force. Now we are using the force centripetally. I think you can see here, we are using the force here centripetally. So thus we can bring back the rexes and make it complete. So now coming to capsulorhexis in difficult situations. There are various types of cataracts like posterolateral cataract, anteriorly fused zonal of fibers, corticocapsular adhesions, pediatric cataract, pseudoexfoliation syndrome, subluxated cataract, and in the end, and most important is white intumescent cataracts. So we'll be dealing one by one. Posterior polar cataract, my point is that make a slightly larger opening of 6 millimeter because this is preferred as due to absence of hydrodissection. Removal of epinucleus and cortex is difficult in small opening. It should not be too large as we may be needing anterior capsular support for ciliary sulcus placement of 3-piece IOL in case of posterior capsular loss. So it should not be larger than 6 mm and it should be not anywhere near 5. Then we come to anteriorly fused zonular fibers. You can see these zonular fibers in such eyes on starting rexes, it gets difficult to control it and it tends to extend to periphery. And if one tries to pull it in, the whole bag moves. I think we must have experienced, all of us, this particular phenomena in these type of cataracts. So one has to judge this, see these zonular fibers and plan accordingly. So stop immediately and look for small strands of zonules anteriorly attached. Aim at smaller rexes with very gentle centripetal force centrally. It should be inner to where the zonular fibers are attached. And after rexes, implant CTR in such cases. And after IOL implantation, enlarge the rexes slowly to the desired size. So when the next is rexes and corticocapsular adhesions. So when there are corticocapsular adhesions, you can see that this part is having the corticocapsular adhesions. So here it is better to do slightly larger rexes in this particular part so that it gets easier to do hydro procedures to separate such adhesions. Because if we have a smaller rexes here, we will not be able to separate the corticocapsular adhesions and the nucleus rotation becomes difficult. Then coming to pediatric cataracts, we all know the anterior capsule is extremely elastic. Always stain with trypan blue because this decreases elasticity to some extent and increases the visibility. Force is to be applied centripetally rather than tangentially. Always use higher end viscoelastic like Hilon GV as chances of runaway is very high in pediatric anterior capsular access. Always keep chamber deep. It should not be too deep. Like it should be adequately deep, but it should not be too deep because that also creates a problem due to low scleral rigidity and combined with the extremely elastic anterior capsule. So here, after we make the neck, we prefer to make the rexes with the capsulorhexis forceps. This is the micro capsulorhexis forceps that I was talking about. So here you can see that the force is not tangential. The force is centripetally. We are pulling it in all the time. And once we have completed this, we enter from the main port because we don't want that the capsule should go in the periphery. And this is how it is completed. So again, I am saying the most important part here is the centripetal force, use of forceps, and you may have to change the port entry. Now coming to pseudo exfoliation syndrome. So here make a smaller axis and avoid the peripheral capsule. Use the CTR, complete phaco gently, and then enlarge the rexes if needed after IOL implantation. So always stay in use forceps for better control. We are always inner to this pseudo exfoliation material. So always remain inner to this exfoliation material. And complete the rexes with the forceps. Now coming to subluxated cataracts. So the key to success here is first aim at smaller capsular opening initially and enlarge later before hydrodissection. As small capsular axis decreases turbulence in the bag, start the capsular axis diagonally opposite to the site of subluxation. This is very important. And always use good cohesive viscoelastic and keep chamber depth maintained. So you can see here that we are starting, this is the subluxation, we are starting away from the subluxation and trying to make a smaller axis here. So this is how the axis is completed. Coming to white intumescent cataracts. This is the most important part in capsulotomy because all of us are going to face problem, and whatsoever expertise we have, there will be a chance that we will end up having a Argentinian flag sign. So we should know all the techniques which help us in taking care of the positive intralenticular pressure. I have been presenting this video in ASCRS conference also. The root cause being is positive intralenticular pressure due to trapped liquefied cortical fluid under the anterior capsule. Always use higher order viscoelastic sodium areate, and removing the trapped fluid is key to success, along with balancing the shearing and tearing forces. There are various techniques to handle positive intralenticular pressure. These are conventional capsular axis, that is essentially a two-step procedure, making a small opening in the center and allow the fluid to drain out slowly. This is a passive method which allows the fluid to drain out on its own, and then make a small rexis. And once the IOL is implanted, enlarge it. Second is phacoemulsification, puncturing the anterior capsule in the center with normal tip bevel down or Kelman tip bevel up, purely torsional. I will be showing this video. Then third technique that I usually popularize is suck and massage technique. Suck the fluid from small opening and then massage the mid periphery gently to the center to remove the trapped fluid, because the fluid is trapped in the mid periphery. Then there is a spiral technique, that making a smaller opening and then spiraling it into a larger opening. Then there is another technique that you give a YAG laser shot in the center and this and shift the patient to OT. There should not be much time between that, maybe within half an hour or so that the fluid comes out slowly and intralenticular pressure is decreased. Sixth is aspirate with 26 gauge needle from center with needle stationary. So these 6 and 2nd are actively you are pulling out the fluid, whereas in 1st and 3rd we are passively draining the fluid. To avoid the Argentinian flag sign. So when we are doing a two-step procedure, we just make a nick and allow the fluid to drain on its own, then replenish the visco and make a smaller axis. You can say that it is just a 3.45 to 4 millimeters, but this needs enlargement later to avoid capsular phimosis. So we are enlarging it. Second technique is phacoemulsification. The settings are phaco only, torsional 80% fixed, vacuum 150, flow rate 28, and enter after injecting higher order visco with foot position 0. Now introduce phaco handpiece after staining and adequate visco. Go directly to position 3. Just appreciate that there the fluid is getting sucked and the positive intralenticular pressure is gone. Now there is another clipping for the same. Again, see that there is a sudden flattening once we go to position 3. We directly go from 0 to position 3. Now then comes the second massage technique. This is a case of phacoemulsific glaucoma. Here we make a small neck, let the fluid drain on its own, and then again we replenish the visco, putting the iris in. You can see there is a very high intralenticular pressure and intraocular pressure. Then we suck the intralenticular fluid that has come out, and then we keep on injecting the visco and massage the mid periphery so that the fluid that is trapped in the mid periphery comes out. And this is the direct fluid suction using the 26 gauge needle bent down, direct puncture of anterior capsule and suck. Again, you can see that the fluid is taken out, and now we can easily do the rhexis because the culprit here is the positive intralenticular pressure. So in wide intumescent cataract, one can use any technique best suited to one's hand. But the important carry-home message is that unlike normal rhexis, it is must to decrease the positive intralenticular pressure in these eyes, apart from balancing shearing and tearing forces by accomplishing CCC. That is how we can avoid the Argentinian flag sign. These are the normal needle or the forceps that manual capsulorhexis we are doing, all of us are doing, but now newer technologies are available like femtocataract. Femtosecond laser is used to create desired size and desired location of rhexis, extremely accurate and can be almost universally achieved in all cases. Here, cost of machine is a concern. And also, here what happens is that the margins are not as good as in manual rhexis because the electron microscopy picture, if you see, it shows a postal stamp type of serrations. Then coming Zepto precision pulse capsulotomy. This uses disposable handpiece and tip. Then there is Virus ophthalmic caliper. A disposable silicone ring is injected and placed on anterior capsule and rhexis performed. This was introduced by Michael J. Travella in 2015. This provides simple, cost-effective option, cost-effective as compared to femtosecond, not as compared to manual capsulorhexis, but it gives you better sizing, positioning, and opening. It is predictable and reproducible. The femtolaser capsulorhexis, we know that it can give you precise placement with significantly less unintended variations in location and diameter, more reproducible, precise diameter, uniformly circular. The cost of machine is the limiting factor. The limitations of femto are, as I already said, that the integrity is compromised due to inherent architecture due to postal stamp like micro perforations, because here it is the laser pulses which are making the perforation. In manual, we are making a continuously edge capsulorhexis, and there can be some additional aberrant pulses which can cause further damage. Abel et al. Has reported that rate of anterior capsular tears during phaco were higher in femto than manual rhexis. And scanning microscopic images have proved that laser capsulotomy has inherently irregular edge as compared to manual rhexis. And there are higher incidence of capsular block syndrome. Coming to plasma blade capsulotomy, Plasma technology is used to create nearly resistant-free sharp incision into anterior capsule under OVD. There is a electrosurgical based unit attached to Fugo blade tip. Blade filament is placed in contact with capsule and tip moved in a circle 360 degrees, maintaining contact with the capsule. Now, what are the advantages? The advantages are that we don't need a red reflex here or we don't need a staining here. This can be done in small pupil also by ablating anterior capsule under the iris. Otherwise, in manual rexes, if we have small pupil, we have to use pupil dilators, either iris retractors, or we have to use other techniques of pupil dilators. Then coming to precision pulse capsulotomy, that is Zepto. Now, PPC is performed using device with soft collapsible tip and circular nitinol cutting element connected to control console. Nitinol super elastic, allowing tip to go from normal incision 2.2 to 2.4 millimeters. Later on, once it is in, it re-expands into circular shape. PPC system delivers fast electrical pulses over 4 milliseconds, preventing any dissipation. Gently pressed on anterior capsule without any pressure. Suction applied to ensure uniform application of energy on anterior capsule. And after capsulotomy, suction reversed and tip taken out of AC. The advantages are that the margins are much smoother as compared to femto. It has stronger strength. Complications are higher rate of incomplete rexes as compared to manual, higher incidence of radial tears when done under dispersive viscoelastic. I have borrowed this video from my friend Dr. Suresh Pandey because I am personally not having the Zepto. So this is a small video. There is a disposable handpiece which is taken and attached to the console. We usually fill it with the fluid before we attach it to the handpiece. And from the other end, we use a syringe to suck out this fluid. After that, it is attached to the console. And once it is in, you can see that the position at the desired site. Then we apply suction. Once this suction is applied, we can see the water molecules. There is a suction and there is a instant rexes, you can see that. So we can get the adequately sized rexes here. So apart from this, there were other techniques which are being popularized. There's a triangular capsulotomy by Vajpayee et al., inferior linear capsulotomy, aspiration of milky cortex, reverse triangular capsulotomy, crossword capsular pinch technique for highly elastic or deficient zonal spot cataracts. Anterior capsule pinched between two 30-degree needles until one of them penetrates the capsule and makes a small flap. Then CCC done. But all said and done, presently, if we see the manual capsulorhexis, if done properly, and if we have taken care of all the difficult situations as I have shown in the videos, that is the best and that is the cheapest. Then there is one Virus silicone ring. I'll just talk about it. The device is made of silicone. It's a donut shape with a 5 millimeter central aperture and a micro pattern etched on the silicone surface that contacts the anterior capsule. The inner opening provides a caliper for precise capsulorhexis sizing. The inside edge of the ring serves as a guide for the leading edge of the CCC. So micro pattern allows the device to adhere to the anterior capsule and remain stable once it is positioned. So this is how the capsular access is achieved. Thank you. I just do the stop sharing and then we can go in for discussion and the questions.
Thank you so much, sir. I really want to commend for an exceptional presentation on capsulotomy techniques, and your vast experience and depth of the knowledge was really evident throughout the session. Videos were also excellent, and each and every point was covered very in depth. Thank you for that enlightening presentation, and I think this presentation will definitely help the understanding of capsulotomy techniques for many of our listeners. Thank you so much, sir. I would like to ask our chairperson, Colonel Dr. Vijay sir, to give his comments, please.
Yeah, I think Dr. Neeraj sir has covered all aspects, starting from the beginners, what all things they have to take care of, while starting with the capsular access and also covering all the special situations and then the recent advances. So this was a comprehensive talk about capsulotomy. He has covered all aspects of it. And there are some things which I just want to add. That is, everyone has to be proficient with both cystotome and forceps, because forceps help a lot in, especially in difficult situations, to basically salvage any radial tears or anything. So that is for the PGs. And for the PGs, again, this is a very crucial step for their transformation from SICS or ECCE towards phacoemulsification. SICE, CS or ECCE, it may be forgiving if they have some radial tears, but in phaco, the radial tears are not forgiving. So they have to master this continuous curvilinear capsular access. And for that, they can either use the simulators or they can use a wet lab, dry labs, maybe onion or tomato, or even a thin sheet of paper to practice before actually proceeding on to the live patient and doing that. So it has to be in their mind, especially when they are transforming. Every time they have to think about what wrong they are doing. They have to re-see their videos, especially during the when they are going for a continuous curvilinear capsular access. Sir has covered everything beautifully and comprehensively.
Thank you, sir. So I have a question, sir. If in which cases would you consider using a Utrata rather than a cystitome, or for all cases do you try with a cystitome first, and if things go wrong or if it's a complicated case, only then you shift to Utratas, or there are some scenarios where you would not even use the cystitome and directly go on to the Utratas forceps?
So one situation here is the pediatric cataracts. In pediatric cataracts, it is always better that you use the Utrata forceps, because here the force has to be centripetal. The centripetal force always cannot be achieved with cystitome. Second condition is that you have a intumescent cataract, and the moment you make a small nick in the center, and it is opening up. So now, if you try using a needle, you are definitely going to increase and lead it into Argentinian flag sign. So here, after injecting good viscoelastic and trying to remove whatever cortical, whatever fluid is there trapped, it is better to use the Utrata forceps from the very beginning.
Right, sir.
So these two conditions are one where you can use the Utrata. You should use the Utrata forceps from the beginning itself.
Right, sir.
And otherwise, whenever you are losing the edge, again, you have to shift over. That I have already shown that when there is a runaway axis, you should use. But these two particular conditions, and then even in subluxated cataracts, it is better because you are having a more controlled approach when you are using a Utrata forceps, and that also the micro Utrata forceps that I showed.
Right, sir. Like you told in hypermature cataracts, because you don't have the support of the nucleus, it's floating on the fluid, the cortical fluid, doing it with the cystitome would be very difficult, nearly impossible. Right, sir. Another question, recently also encountered one case. Usually these long anterior zonules, the LAZs, they are weak and they do not usually affect the rexes, but sometimes I had a case a few days back where they are quite strong and it doesn't allow the rexes to go. What technique do you use then, sir?
you are talking of anteriorly fused zonular fibers, which are very strong.
Yes, sir. The long anterior.
Okay, so we have faced many such situations initially when we were not knowing that what is happening. But when we start doing the normal size rexes in these cases, the whole bag is getting pulled up, and
Right.
we are not able to cut the capsule at all.
Proceed
So
further.
here it is better that we make a smaller rexes first and try to spiral it out if possible. If not possible, do the phaco in a smaller axis, and after you have completed the phaco, implant a CTR here, and then you do the increase in the rexes in a second step.
Also, in such situations, what sometimes we do is, if your axis you have already started and it has margin has reached near the zonules and you are trying to pull but it's not coming, then you can use a MVR scissor just at the same side where that axis cut margin is there, and you circumvent that thing by cutting with the MVR scissor. So in this way, you at least bypass that pull that will come by pulling the excess margin. So that especially if you're stuck up in that situation. Otherwise, if you can do a small axis, that is the best option, and you can go ahead and complete the surgery. And
sometimes these zonules are very long, and doing a small axis also becomes almost impossible.
Yes.
Can we break those zonules with a needle first, and then I tried doing it. It wasn't very successful, so I had to go. I can show that video if we have time. I think we have time.
I think you can share that. It will be good.
Yeah, I'll just add one thing. Once the question of scissor has come up, I think I missed out one slide, and that is a situation when we have a calcified anterior capsule.
Yes.
So those conditions, again, we need to cut it with the scissors and complete the rexes, because these two conditions, yes, we need to use the scissors. There's no other way out, basically.
Right, sir.
So in that case, with bimanually, with one you can hold the rexis margin, and other you can use the scissor and cut the margin. Yes.
So this was the video. This is the case I did, I think 4 or 5 days back. As you can see, the zonules are coming up till here. So up till here, so almost till the middle. I was aware that this would be a difficult case. I started off with the needle, and see, the rexis doesn't move. So I tried breaking those zonules, but they were unusually very strong, and didn't allow the rexis to go any further. And what I did was to make a half rexis here, because the zonules on this half were not as many as on this half. So I could complete half rexis there. Now it will be very visible. And then I took a micro rexis end grasping scissor, and then make a flap there. And then come with a forceps, I tried completing the other half. Ultimately, I could do, there was a small flap there, but this is how I thought if some other technique we can use.
I think this was very nicely managed. So sometimes you have to innovate during the surgery, because you never know, in very rare situations you may end up something like this. And I think we have to be very handy with the scissor and forceps and all the things available with you. And it was handled very well. And also
Actually, the beginners
there is a
should.
calcification in the lens, and anterior capsule is very thick, or post-uveitic cataract where there is a very thick membrane over the anterior lens capsule. So where the needle, even sometimes you can't puncture the anterior capsule. So you have to make a cut with the MVR, then make a margin, and then maybe use a scissor to circumvent that fibrous part, and then complete the rexis. So
right, sir. Neeraj sir, you were saying something.
Yeah, I was saying the same thing, that the calcified capsules, again, as has been explained, is a big challenge. but you have managed this case very well. And for the beginners, they should know that these type of cases, you see that there's absolutely good glow. And until or unless you really look for and you have a good microscope, many times you just miss out these entirely fused zonal of fibers.
I'm lucky to have a good microscope.
Uh-huh.
But yeah, in training hospitals and medical colleges, sometimes you don't even perceive that. So on slit lamp examination, just pre-op before we take up for the surgery, pre-op examination has to be done, seen by the surgeon for each and every case. That's a very good point, sir. In case of a runaway rhexis, or say if you have converted to a can opener, and the patient has a toric IOL, anything special that we can do in that situation, sir?
Usually, I avoid putting a toric IOL if I don't have a complete rhexis, because the rotational stability here is a big challenge. But yes, if you are really pressed in a situation and your axis of placement is away from where the rhexis has given way, you can try that.
Right, sir.
So, but if the axis of placement is at the place or it is near to that, so never put it, never put it.
Right, sir. Dr. Kanika, do we have any questions online?
So we have one question, but I'm unable to understand the language. I think Dr. Sadaf has asked, in Zepto capsulotomy, what does Sir mean by reproducible capsulotomy?
Reproducible means that because the size is the same, so we are every time we know that what is the exact size we are getting, the size is reproducible. Then the location, as we are putting it in the center, we know that where exactly we are putting it, the size and shape both are reproducible.
Yeah, that's the advantage of both Zepto as well as Femto as well. You can get reproducible rhexis, and you can customize in case of Femto as well. Like Sir told in his presentation that in cases of say subluxated cataract, there I think the Femto really shines. You get a centered on the rhexis is centered on the capsule on the center of the lens itself. Even if that center is not the center of the pupil. So because after the capsulotomy, you might, or after removing the nucleus, you might put a CTR, which would center the lens in the pupillary axis. But if your rhexis, if you've done it manually, you might not get that kind of a centration, where the femto really shines.
I agree, sir. In fact, femto, that anterior segment OCT also helps guide on the subluxation degree. So that can also give a clue to the cataract surgeon as to how the forces have to be manipulated. We have one more question, sir. From where should we hold rhexis while using Utrata forceps? Should we follow rule of triangle?
We should always it has to be at the edge, as near to the edge, because the more far off are from where it is getting teared. So the point where you are tearing, it should be nearer to that, because then the tangential forces that you are using will be much better controlled.
Approximately 2 mm from the margin where your tear is, and then come back again after a few clock hours, and then readjust it again and again. This is what Sir also showed in his videos. Especially for the beginners, for a trained hand, it goes can be a quadrant and then you shift. But for the beginner, after probably every 2 clock hours, you shift back to that position, close around 2 mm, close to the margin where you're cutting.
Absolutely, you get the best control if you are closer to the edge, and more further you are from the edge, then the control is less. So yes, for the beginners, they have to do it many times. They have to come back to the again margin and then go slowly. But yes, experience can do that.
So the tiny tears, that is what I said, that you keep on
Yes.
making tiny tears.
Yes.
Another question that we have, sir, is how to do a rhexis in case of a central macular leukomatous corneal opacity. You don't have a good cornea, I think.
So As far as I am concerned, in central this macular corneal opacities, what we use is we use the chandelier or illumination we put up through the side port, and then that can illuminate after a well stained capsule which is stained with the trypan blue. Then you can actually get a good hold of it. Otherwise, you can go through the pars plana route, and then again you get a good endo illumination, and on that you can do a good access.
The chandelier really makes a difference.
Yes, yes. It's
So
very
you need
convenient, and once you get used to it, putting a pars plana port, after you put it, it's very convenient after that.
Neeraj, sir, you were saying something.
Yeah, I was saying that if you're not well versed with the pars plana, it is the lateral illumination, that is the only way that it helps out, because once the light is from the top and you have opacity in between, you don't get the glow and other things. So it's not possible.
One point that I wanted to make was for the beginners and the PGs is always use new needles. In some training hospitals, you might even for cost cutting purposes, you might eat your needle as well. Doesn't make sense. It's just 5 rupees, 10 rupees, and always use new needles and bend them right before you start your access. Sometimes just to save time, we bend it at the beginning of the surgery before we start the surgery and then keep it beside. That can sometimes rub against other instruments or from the cloth of the OT table, and the tip can get bent or even blunt, and you won't get a very good access. So bend every time, and just before you start the access, give it a few seconds. It's just a few seconds. It's not going to save a lot of time.
I think Dr. Amit has come out with a very valid point here, because many a times even we have faced this problem having a long list. What our assistant does it that they know, okay, there are 10, 12 cases lined up. They'll make capsulotomy needles in the beginning and they get bent. And then you have problems in that. This is a very valid point.
Dr. Kanika, you were saying something? The question do we
I
have?
just wanted to ask one question from Dr. Neeraj, sir, for the benefit of the residents. So, what is the adequate size of a capsulorhexis? And is there an arbitrary number that you have to follow? Secondly, how to guide residents and how to train the new surgeons to get an approximate idea of the sizing of the rhexis if they don't have any image guided tools?
See, if you don't have any image guided tools, the first is the size. Size should be anywhere between 5 to 5.5. Ideal is 5.25 to 5.5, because there should be, usually the optics we are using are 6 mm. So there has to be a complete 360-degree overlap that we want to achieve. Now there are certain rings available which are very cheap. So what you can do is you can put a mark with that ring on the cornea initially, because if you're not experienced, initially you can do that, and then you can just follow that mark and make the access. So those rings are easily available. They are autoclavable, so you can use those things.
Right. And if you have a femto, just for the beginners also, if you are not doing the femto, but if your senior is doing a femto, go and see the size. So that's the exact ideal size that you should aim at, right? Because it's a 5 mm, you know that this is exactly 5 mm. So you see a few femto cases happening, observe them, observe the size. That's the exact size that you should aim for if you have a femto in your institute.
And another aspect that the residents they do initially is in pursuit of making an ideal axis of 5.5, and also they are afraid that it may run away. They end up making a very small axis, maybe
Small,
4.5, and then that has to be extended many a times. So it's very important. The sizing is very important over a period of time. Initially, for at least my residents, what I tell them that you go for a 6 mm rather than for a 5 or a 4.5, making and ending up with a small rexes, because initially they have to do a skirt and all this, then they end up eating away the edge of the rexes if it is too small. So it's important. Sizing is very, very important. Yes.
And in case of a small pupils, again, size would be difficult. But any special tips on small pupils, making a rexes in a small pupil?
Small pupil, the best way is that always use the pupil dilators before you make the rexes. Because if you think that you may be able to do phaco, but the as far as rexes is concerned, always use pupil dilators.
Right.
And then only make, because otherwise if you think that you want to do fast and you can go under the iris, that is the worst thing one should aim at.
Never do a rexes blindly below the iris. That's a good point. And another point there is that if you have done a rexes and then you put in the iris hooks, or that can entangle the edge of the rexes also. It can capture the edge of the rexes and you can have a capsular tear there also, can run off.
And the whole bag is pulled up.
Yeah.
That can even cause postcapsular rupture also. You know, it comes nearer to your phaco probe.
Do you have any other questions, Dr. Kanika?
No, sir, I cannot see any other questions on the YouTube platform. I think in the chat box, we have one more question. Would you like to attend, sir?
What do you do if there is capsular phimosis, and how do you manage if it is causing visual symptoms?
So once we have, first thing is I'll tell that that is why we have been talking on the sizing part. So once we get a case of capsular phimosis, we need to very gently try to dissect it out. Like we have to use a needle, sharp needle to do it. But if we are not able to do it and we don't want to do a intraocular procedure, we can make some YAG shots on that. Even that can release the pressure and release the pull on these zonules. So many a times the YAG cutting of the anterior capsule helps. But if it is not helping because they are very thick and very highly fused, then you have to go intraocularly and do it with a needle, very slow dissection. And it is really a very cumbersome procedure to do that.
If you don't have any other questions, I think I'll ask our chairperson to give his final comments.
Thank you. I think Neeraj sir has done a wonderful job covering all aspects of capsulotomy for the beginners, for the special situations, and also the recent advances. So it was very beautifully covered, all aspects of capsulotomy. Thank you.
Absolutely. So thank you. I would like to thank both our speaker and the chairperson for their valuable time. And this lecture would definitely help a lot of young surgeons and even experienced ones. So thank you everyone, Dr. Kanika, Dr. Ishita, Dr. Kritika. Thank you for all your support.
I'll here like to add and thank Dr. Santosh for this, innovative idea which has been going on for years and years and become so popular. And he has involved almost everyone. And I'm proud to say that I was his batchmate at AIMS and we passed out together in 91.
Wonderful. Yes, iFocus has become one of the best teaching platforms of the PGs in not only in this country. I think we have audience from all across the globe, and rightfully it has become the mother of all PG teaching programs. So,
Thank you, everyone. Thank you, sir. Quite a reminder, not to forget, we have a physical iFocus going to be held in Hyderabad from June 9 to 16. The early bird registration closes soon, so please hurry up.
thank you and good night.
Thank you. Thank you very much. Thanks.
So thank you, Neeraj sir. It was such a great, delightful talk, and
Thank-
so many of new videos that we cannot find online, even through search. And this shows how vast experience you have had in the field. Really enlightening for us.
Thank you.